Hello. Hello. Good afternoon, everyone. Welcome to oral communication on cardiovascular topic. We have 3 speakers today, this afternoon, and each speaker have a 10 minutes talk and 5 minutes question and discussion. Our first speaker is Rayomand Khambata from Queen Mary University of London. And his talk of today is a local delivery of nitric oxide prevents endothelial dysfunction in periodontitis. Okay, Rayomand?
All right, thank you.
Your time.
All right, thank you. Thanks to the organisers for giving me the opportunity to present my work today. So I'll be talking about inorganic nitrate, periodontitis, and endothelial dysfunction. So in the healthy gum, there is a symbiotic microbial biofilm that helps maintain oral homeostasis. Now, individuals who have poor oral hygiene exhibit dental plaque buildup, and this leads to a mild inflammation of the gums, which is termed gingivitis. So as this disease progresses, periodontitis ensues, and this consists of severe inflammation, alveolar bone loss, and the formation of a periodontal pocket, which allows the bacteria and any associated pro-inflammatory mediators to enter subgingivally and into the systemic circulation where they may have effects. Now, what's interesting to note is that 11% of the world's population suffer from severe periodontitis. And also, individuals with periodontitis have a 20% increased risk of cardiovascular disease. And this is actually increased to 25% in those with the most severe form. Now, what links these two diseases is actually endothelial dysfunction. And one way to measure endothelial function, a non-invasive measure of this, is flow-mediated dilatation of the brachial artery. And what we can see here is that individuals with severe periodontitis have reduced FMD responses, indicating that they have endothelial dysfunction. Now, in the cardiovascular system, NO generation is via endothelial nitric oxide synthase, and this is termed the canonical pathway. Now, NO has 3 major actions. It inhibits platelet reactivity, it promotes vascular smooth muscle relaxation, and it inhibits leukocyte activation. Now, endothelial dysfunction is synonymous with a lack of bioavailable NO, and this is in part due to a lack of functional eNOS. And this is evident in individuals with cardiovascular disease who have lower levels of the metabolites of NO, which are nitrite, NO2-, and nitrate, NO3-. Now, within the body, there are 2 sources of this nitrate. One is from the metabolism of NO, shown here, and the other is from the diet. So green leafy vegetables, including things like beetroot, contain inorganic nitrate, and when we ingest this, this is reduced to nitrite via bacterial nitrate reductases found within the oral cavity, and this nitrite is further reduced to nitric oxide by a variety of enzymes, but as a group, we're very interested in xanthine oxidoreductase. And this entire pathway is termed the non-canonical pathway for NO generation. So therapeutically, it's whether inorganic nitrate could have clinical utility. So the aims of our study were to assess the effect of dietary nitrate as a method of NO delivery into the systemic circulation in a mouse model of periodontitis, and also to investigate the effect of nitrate on the associated endothelial dysfunction, and to investigate if we would see any anti-inflammatory effects. So the first thing we did was set up a model, and we used a technique which involves placing a ligature around the second molar bilaterally, and this is kept in for 14 days. So in our first set of studies, we did a sham control and a ligature group, and so in the sham, we placed the ligature, tied it off, and then we immediately removed it. In our second set of studies, we did a pre-treatment protocol, whereby we gave 15 millimolar potassium nitrate or potassium chloride in the drinking water for 7 days before the ligature placement, and then we kept that in for a further 14 days. We also did a reversal study where we started it 7 days after the ligature placement, but due to time constraints, I'm not going to show you that data today. So the first thing we wanted to do was, did we see alveolar bone loss, which is one of the key components of periodontitis? And from this micro CT image, what you can see with the green arrows, there you have the alveolar bone at the top in the sham, and in the ligature, this has been degraded. You can quantify this, and what we see is that there is a significant reduction in the alveolar bone loss. We then also went on to measure the gingiva, various pro-inflammatory mediators. So we did qPCR, looked at IL-1 beta, IL-6, TNF alpha, and they're all elevated. And this mimics the clinical scenario as well. Interestingly for us, we also saw an elevation in XDH, which encodes for xanthine oxoreductase, and we also saw an increase in INOS, which is pro-inflammatory. We also then wanted to look at the amount of bacteria that we were seeing in our model. So we used universal 16S DNA, and we saw that this was increased, and also doing next generation sequencing, we also saw that there was a big shift in the microbial community. We then went on to look at whether these bacteria could actually enter systemically, and so one of the first assays we did was use an endotoxin assay in the plasma, but we didn't see any changes here. We also looked at the aorta using universal 16S DNA, and again, we didn't really see any changes. However, interestingly, we did see an increase in the heart amount of DNA, in the heart and the amount of bacterial DNA that was there. Also, what was interesting to note is that we also saw a neutrophilia within the plasma, and this again mimics the clinical scenario. So then we investigated more, we looked into the heart a bit further, and we did some qPCR, and we saw elevations in IL-1 beta, TNF alpha, and a trend towards a reduction in IL-10, which is an anti-inflammatory cytokine. We then went on to look at endothelial function, and so using the organ bath, we mounted the aortas, and we looked at the acetylcholine response, and what you can see here is in the squares, there is a reduction in the acetylcholine response, suggesting that there is endothelial dysfunction. We also gave sperminonoate, which is a direct ono donor, and also the phenylephrine, which is our contractile agent, and there was no differences, suggesting that there was no changes in smooth muscle functionality. So basically, we faithfully recreated periodontitis in our animal model. So what did inorganic nitrate do in all of this? So the first thing that we did was look at plasma nitrate and plasma nitrite levels, and we saw that they were elevated equivalently in both groups, suggesting that the enterosalivary circuit, so that non-canonical pathway that I showed you, is still intact. In terms of alveolar bone loss, we didn't really see much of a difference. And when we looked at the gingiva qPCR, we saw a reduction in IL-1 beta and an elevation in IL-10. However, we saw no change in IL-6 and TNF alpha, suggesting that any effects that we were seeing were quite modest in terms of the periodontitis itself. We also looked at the structure of the microbial community, and again, we didn't see any changes here. So if we did see any changes further on, it was most likely not due to changes in the bacterial community. And then coming on to the most exciting data that we got, and what you see here is in the black squares, what you can see is that the endothelial function was completely reversed with inorganic nitrate. So we were protecting it against that endothelial dysfunction. Again, the sperminonoate phenylephrine curves were equivalent, so smooth muscle functionality was intact. We also then went on to look in the coronary vasculature. So we used the Langendorf technique, and we looked at coronary perfusion pressure. And what you can see here, in the KCL group, when you add LNA, this basically had very little effect on endothelial function. So, but when we gave nitrate, we saw a restoration of the effect of LNA. So again, intimating we were seeing endothelial dysfunction within the heart as well. And responses to sodium nitroprusside was equivalent. So we wanted to try and find a mechanism for what we were seeing. So we did some Western blotting on aortic homogenates, and what we saw was an increase in phosphorylated enos, suggesting that this was a potential mechanism where inorganic nitrate was causing enos phosphorylation, which is what was rescuing the endothelial dysfunction that we were seeing. In terms of other systemic effects, we saw a reduction in the neutrophilia, and we also saw an increase in heart IL-10 mRNA. Interestingly, we also saw an increase in heart CXCL5, and the CXCL5 has been shown to be protective in cardiovascular disease, and we also saw a reduction in CCL5, which has been shown to promote cardiovascular disease. So we're having some anti-inflammatory effects within the heart as well. And then finally, one other media we wanted to look at was reactive oxygen species, but in particular superoxide. So at basal levels, we didn't really see any difference. But interestingly, when we provided xanthine, which is the substrate for xanthine oxoreductase, what we did see is that there was a significant reduction in the nitrate-treated group. When we provided NADH, or if we provided NADPH, which is just the substrate for NADPH oxidase, we didn't see anything. So this data suggests that it's xanthine oxoreductase-driven derived superoxide may be driving that endothelial dysfunction that we're seeing in this model. And so finally, to give a kind of clinical translation, what we wanted to investigate was whether basal basal plasma nitrite levels were altered in periodontitis patients who had endothelial dysfunction. And what you can see here, unlike in healthy individuals, plasma nitrite did not correlate with FMD responses. And what we suggest is that maybe giving an organic nitrate may help restore this, but clearly a clinical study is needed to prove this. And so in summary, what I hope I've shown you today is that in periodontitis, there is a change in the microbial community, and you also see an increase in pro-inflammatory mediators. This then drives cardiac and aortic endothelial dysfunction, which is driven by increases in neutrophils and superoxide production. And when we go in with inorganic nitrate, we can have a modest effect at the site of the gingiva, causing an anti-inflammatory effect. And also at the site of the heart, we can get reductions in superoxide production and increases in IL-10, the anti-inflammatory cytokine. And also within the conduit vasculature, we see decreases in neutrophils and superoxide production. And so just in summary, inorganic nitrate could have potential clinical utility in terms of reducing that cardiovascular dysfunction in patients with periodontitis. And I'd like to thank all the group, and in particular, Dr. Daniel Fernandez, who helped set up this model in our lab and contributed a lot of this work as well. And thank you, everyone.
Thanks very much for Rayomand, for your excellent talk. Very good. So we have time for 2 quick questions. If you have a question, you can come to the microphone there. Any question? Rayomand, actually I have a question actually this is a chronic inflammation caused cardiovascular disease, right?
Yeah.
And coronary artery disease, could you more clarify what kind of, is more leading to atherosclerosis, or what kind of coronary artery disease?
Okay, and so in our model, it's a very acute model. So it's only 2 weeks worth that it's in there. You can't leave it in there for much longer because actually because that alveolar bone loss is so severe, they will have tooth loss. So the longest I've ever seen a model is 1 month. In terms of clinically, yes, so endothelial dysfunction is the very early stages of what you'll start to see before you start to get atherosclerosis. And then also, I mean, there is some data showing that periodontitis patients have an approximately 30% increased risk of having a myocardial infarction as well. So it is a much more chronic disease, but will be generation of atherosclerosis.
Are there any correlation to hypertension?
Yes, because it's that endothelial dysfunction, it's that loss of endothelial-derived NO, and yes, it's correlated. So.
And in the drink water, how stable the nutrient and
so the nitrate is
nitrate.
Yeah, so nitrate is actually pretty stable. So what we do for our preclinical studies is we change it every 2 to 3 days. But even if you check it for over a week, it's still there at the same concentration. It's nitrite that is not as stable. It's highly reactive. Nitrate. But inorganic nitrate is stable.
Do you think in any of a supermarket, like Tesco, provide this kind of
drink?
Yeah,
so beetroot juice.
Beetroot juice.
Beetroot juice, yep. So beetroot juice has inorganic nitrate. And I mean, other things like spinach, rocket, all of these foods contain inorganic nitrate, but beetroot juice has inorganic nitrate, it's stable, and we do that in our clinical studies, that's what we use.
Excellent. Thank you so much. Very, very interesting and translational. Thank you.
All right, thank you very much.
Thank you, Rayomand. So, yeah, good applause.
Oh, question. Oh, sorry.
Oh, sorry. Professor Du from China. Yeah, Professor Du from China Pharmaceutical Society. Yeah, Professor Du.
Yes, thank you. It's a very, very good work and the presentation. My question is, why you chose the oral information in inflammatories for the experiments, and how about other part for the inflammatories? Use the dietary with a nitrate. Is okay?
So, sorry, did you say why did we choose that model?
You choose the model of oral.
Yeah, why did we choose that to investigate cardiovascular disease? Well, the reason being periodontitis, so I said about 11% of the world's population have severe periodontitis, but if you look at any kind of gingivitis, periodontitis, there's about 50% of the world's population have that. So there's a big, it's classed as the 6th most abundant disease. So that's why we chose oral to look at, we wanted to look at that periodontitis, but also it's because it's something that's not been looked at that much within the literature. It's seen that there's this association between perio and cardiovascular disease.
Yes.
But, sorry.
Normally, I think people think about the dietary with the nitrate will be not so good for the health.
Oh no,
and
so okay, yeah. Oh, so that's the question, right? So inorganic nitrates. No, so there is some work with nitrite, definitely. So things like where you're using nitrite, there is a lot of data out there about having high doses. Inorganic nitrate. So nitrate is found in green leafy vegetables. So even if you're looking at the DASH diet, I forget what the acronym stands for. So those levels are very safe. And so there aren't any, we haven't seen, we've done lots of clinical studies looking at methemoglobin, and there's no issues with that in terms of causing cancer.
Okay, thank you.
Thanks very much for Professor Du. Actually, for our session, one of our speaker withdrew, so we hosted 3 speakers, so which allowed us to have a bit of more time for the vivid discussion. Okay, good. So our second speaker is Danila from University of Glasgow. And her talk is allergic inflammation induced endothelial dysfunction and oxidative stress through interleukin-4 dependent mechanism. Thanks. Okay. Danila.
Hello, thank you for the lovely introduction. And it's a pleasure for me here to talk at the WCP 2023. Today's talk will be focused on how allergic inflammation induces endothelial dysfunction and oxidative stress through IL-4 dependent mechanism. Allergic rhinitis is a very common disease. It affects up of the 40% of the population worldwide. And the allergic rhinitis symptoms are triggered by exposure to different kinds of allergen. Actually, it's speculated that this disorder will increase in the next year because it's strongly connected to the environment pollution. And a very severe allergic reaction due to allergic rhinitis can impair the quality of life. These can affect the sleep condition and can affect also work and school performance. One of the biggest challenges of allergic rhinitis is to address the exact cause of these disorders. This because the medication used for this disorder are not always prescribed, and not always allergic patients consult the GP. However, it's estimated that the cost of this disorder range between 30 and 50 billion euro only in Europe. As I show here, the arrow is transparent is because the medication tend to ameliorate the symptoms of an allergic rhinitis, which are cough, sneeze, runny nose, and watery eyes. However, when again a subject will be exposed again to the allergen, there will be a new allergic reaction. So the cycle will start again. It is interesting to note on the right graph that compared to other non-communicable disease, the allergic rhinitis start before 20 years old, peak between 20 and 40 years old, and then declines. The classic allergic response has a biphasic trend, which is characterized by an early phase, mainly histamine-dominated, and a late phase that appears after 7 hours after the first exposure of the allergen, which is characterized by the release of several allergic mediators, such as eotaxin and Th2 cytokines. It is interesting to note that has been published several papers that demonstrate that allergic mediators released by several immune subsets during an allergic reaction can affect the development of cardiovascular disease. This will open a new insight in addressing the Th2 role in cardiovascular disease development, which is classically dominated by Th1 response. So the next question is, which is the clinical association between allergic rhinitis and cardiovascular disease? To date, the science, the results are very scarce and very controversial. So we still, to date, we don't know if actually there is an association between allergic rhinitis and cardiovascular disease. Also because there are just a few experimental papers that tend to explain the mechanism behind allergic rhinitis, allergic inflammation, and cardiovascular disease. On this basis, my aim of study was to investigate the association and the mechanism between allergy and early vascular dysfunction, because as I said my colleague previously, early vascular dysfunction is the landmark of all cardiovascular disease. In a focused clinical study, we evaluate the endothelial functionality in a group of patients that present seasonal allergic rhinitis. And during the pollen peak season, the allergic patients present a reduction in endothelial functionality addressed by the non-invasive technique FMD and confirmed by endopath. The fact that there is no difference in the nitroglycerin-mediated dilation confirm that this endothelial dysfunction is only related to the endothelium. To investigate the mechanism behind this, we use a male mouse model of allergies induced by ovalbumin, locally, so intranasal, and systemically, with systemic sensitization. And the aorta of allergic mice present an impairment in endothelium-dependent response to acetylcholine. This suggests a loss in nitric oxide bioavailability. However, when we investigated the expression of the main enzyme that produces nitric oxide in the aorta, we surprisingly found that this enzyme is overexpressed. One of the possible causes of overexpression of nitric oxide synthase is the presence of reactive oxygen species or oxidative stress. So we incubate our allergic aortas with NAC, which is a common antioxidant. And the incubation with the NAC ameliorates the impairment seen in allergy. We then confirm the presence of oxidative stress using 3 independent techniques. We evaluate the expression of vascular superoxide in the allergic aortas, which is a significant increase. We confirm this by using the DHE influorescent probe, and by Western blot, we investigate the expression of the main enzyme that produces reactive oxygen species in the vasculature, which are NOX1, NOX2, and NOX4. We found that NOX1 and NOX2 were significantly overexpressed, while NOX4 was significantly reduced. So then we went to analyze, to address the level of the cytokines in the system. And we did this by using the Luminex assay. And we found that in the serum of allergic mouse, we find the classic cytokines that are typical of the late phase response that I mentioned previously, which are IL-4, IL-5, eotaxin. However, we found also the overexpression or the increase of the level of other immune inflammatory mediators that are not canonical. We used single-cell RNA sequencing analysis of already published dataset on healthy aorta to address the expression of the previously mentioned cytokines in the receptor in a healthy condition. And we found that the IL-4, Okay. The IL-4 receptor is highly expressed in the vasculature, mainly in endothelial cells. So then we went to investigate if the expression of this receptor in our allergic model, and we found that the mRNA expression of IL-4 receptor is a significant increase in allergic aortas. So then we incubate our naive aortas with IL-4. And the IL-4 incubation induces vascular dysfunction and endothelium-dependent endothelial dysfunction. But when we incubate with IL-4 and NAC, we found that the presence of the antioxidant reversed this endothelial dysfunction. And we prove that IL-4 induce oxidative stress through NOx1, NOx2, and NOx4 through Western blot. To summarize, we can conclude that the vascular dysfunction that we saw in allergic inflammation induced of albumin in mouse can be explained by the activation of oxidative stress through IL-4, mainly through NOx1 and NOx2. Before to conclude, I would like to spend 1 minute to talk about the next step of this project, which will be to investigate the incidence of cardiovascular events among a large cohort of allergic patients. To do so, we will take advantages of the digital health. Specifically, we will use the Data Safe Haven platform, which allows us to select a young population of patients with diagnosis of allergic rhinitis based on WHO the disease coding, and we will address the link between allergic rhinitis and cardiovascular disease thanks to the cooperation of clinicians, academics, and a team of analysts thanks to the Robertson Center of Biostatistics in Glasgow. In this way, we will try to identify a potential young class of allergic patients that are at high risk of cardiovascular disease. I would like to thank all my research group, the sponsor, and of course, thank you all for the attention.
Danila, thank you so much for your wonderful talk. And question for Danila, allergic and cardiovascular disease.
Hi.
Hi, Danila, very good talk.
Yeah,
Hello,
okay. L2, yeah.
Yeah, very good talk. So basically, probably I got lost during your presentation. You say that there is an overexpression of enos in this inflammatory condition. Are you sure that is not enos? First question. Second question, have you thought to give some enos inhibitors, like a name, to see if you can rescue the process?
Okay, so we saw an expression of total enos. We did not investigate about the inflammatory nitric oxide. So we just now focus on the main enzyme that produces nitric oxide in the endothelium. So we check the endothelium, not nitric oxide synthase. But yeah, this is like a good point. We can also check about the inflammatory the enos. Sorry, the second question is about to give some nitric oxide synthase inhibitor.
To see if you can rescue the...
In vivo, you mean? Or in vivo, we didn't because it's now clear that allergic rhinitis involve upper and lower airways, and nitric oxide play an important role in airway disease. We don't want to reduce the inflammation only because we are targeting the allergic reaction. So maybe we can try to inhibit the nitric oxide in vitro. So maybe using a name and see exactly what happened in the aorta.
Thank you. Very last, if I can. Have you considered that the enos can be uncoupled in that condition?
Yes.
Because you were suggesting that there was an upregulation of enos, production of nitric oxide, which is reacting with superoxide coming from NOx. But it might be that enos itself is a source of superoxide.
Absolutely. We tried, and we encountered some technical issue. So definitely this is like in our bucket list. So
Thank you very much.
Thank you very much.
Thank you. Number one, yeah.
Hi, Iris Jaffe from Tufts. Really nice talk. One thing I noticed, so the patients that you enrolled are patients with a history of allergic rhinitis.
Yes.
And you measured FMD before the allergy season and then during the allergy season. Yeah. So since their FMD was improved before the allergy season, it suggests that perhaps it's reversible, the impairment in endothelial function, and it gets worse during allergy season and then resolves. So I guess my first question is, do you think this is reversible? And if it is, so it's intermittent, what impact do you think that will have on progression of vascular disease?
So yeah, this is a nice point. The first thing is that is reversible, but we don't have to forget that these people take anti-allergy drugs. So it's important to understand if it's reversible is because it's just the end of an allergic reaction or because they actually are taking some drugs. And the other point is that these people are always, because usually these are seasonal allergic rhinitis, this means they are constantly exposed to like allergen. Of course, as I said in the previous slide, these people are for the entire their life exposed to allergen. So of course, this maybe can be a factor of inducing cardiovascular disease if they are constantly under like an allergic response, so they have a lot the release of several mediators. Interesting, has been recently published a paper in which demonstrated a subject with the polyvalent allergic rhinitis, so they are allergic to more than one type of pollen. They have a very high release of Th2 mediators. So it's also important to discriminate this other class of patients that are not only allergic to one type of pollen, but maybe 2 or 3 types of pollen.
Good. So Danila, I have a question. I assume this rhinitis a similar allergic type as asthma, right?
Yes and no. So they are both involved lower and upper airways, but in asthma we see a remodeling of airways. In rhinitis we don't see this. So it's important always to take, to consider asthma if it's not allergic asthma or endemic asthma. And it's a very tricky. When you talk about comorbidities, it's always quite tricky in the allergic rhinitis.
And I was thought mast cells should be more heavily involved rather than T cell. But however, why you focus on T cell rather than mast cell?
We didn't really focus on T cells. By the Luminex, we saw this increase of the classic cytokines. And because in this case, we are focused on the aorta, as I show, we address which kind of receptor is overexpressed on the aorta. Because with the Luminex, we can see several cytokines, as I show. It's quite impossible to go through.
Sure.
But definitely mast cells, and also has been already published that mast cells plays an important role in cardiovascular disease development.
Yes, correct. Thank you. And number 2.
Thank you for your talk. I have this similar question, but it is about why are you excluding PGD2, derived from mast cells mostly, but this one is involved in pulmonary vein relaxation, for example, and could produce edema and so on.
No, thank you. This is a very good point. We're not excluding. Now, of course, we try to focus more on, as I explained, we just saw the expression in the single cells, so we focus on which is the receptor that was mainly expressed in the endothelial, so we focus and we use the Luminex as our starting point. So this is the reason. But yeah, these are an important point, also because allergic rhinitis, allergic reaction, there is the release of so many mediators that if we would like to go through each one, it would be like a massive work.
Excellent talk and discussion. Thank you, Danila. And we welcome our third speaker. Third speaker is Dr. Saltuk Songür from Hacettepe University, Faculty of Medicine, Department of Medical Pharmacology from Turkey. And his talk of today is intrarenal arteries inhibitor different vasoconstrictor and vasodilator profiles. It's your time.
Thank you, and greetings to everyone. I am Saltuk Songür from Hacettepe University, Ankara, Turkey. And first of all, I want to thank all the organizers for this opportunity and this beautiful event, and you, the attendees, for attending this presentation. Today, I want to talk about the different vasoconstrictor and vasodilator profiles of different branches of intrarenal arteries. So the first question is, why did we do this study? Actually, I was doing some research about the topic of my PhD thesis, and I was looking at different vasculatures of different organ systems, and the kidneys tempted me especially. There are two reasons for that. The first reason is that there are different branches and different segments which are suitable for studying, and the more important second reason is that the kidneys receive a high percentage of total blood flow, and thus they form an important peripheral vascular zone, resistance zone in the cardiovascular circulation. So here you can see different branches of you can see the different branches of the renal vasculature. It is starting with the renal artery, which is a branch of the abdominal aorta, and then it divides into its anterior and posterior branches, and then it continues with segmental artery, interlobar artery, and then arcuate arteries. Each of these individual arteries and this vasculature becomes important in certain diseases, and there's this equation: renal blood flow equals to renal blood pressure divided by renal vascular pressure, renal vascular resistance. Each of these individual components of this equation also becomes important in certain diseases. So in this study, we have decided to investigate the differential responses of these arteries, different segments of arteries, to different pharmacological agents. So the next question is, how did we do it? We have started with 8 to 10 weeks old male sprachtal rats weighing about 250 grams, and we have anesthetized them with intraperitoneal anesthesia. After the abdominal incision, we have excised the kidneys, and we have cut them coronally into 2 pieces. Here you can see them. And then we have transported them to the microscope. Here is a microscopic image of that kidney. And here it is after the eclair isolation, without any harm to the vasculature. Here you can see the renal artery, the branch of the renal artery, and the segmental artery, which we have used in this study. There are actually more distal branches, like as I have said before, the interlobar arteries and arcuate arteries. We have isolated them and tried to generate data from them, but it was hard to get consistent and robust data. So we have stuck with these 3 arteries. And then we have transported them to the bath of the viromyograph system. Here you can see a bath of this system. We have used 40 micrometer thick wires for the renal artery and the branch of the renal artery. And then we have used 25 micrometer thick wires for the segmental artery. Here is the viromyograph system and the whole system which we studied on. And then we have started our protocol. And here are the results we had. For clarification, in this slide and the continuing slides, we have represented the renal artery with blue, the branch of the renal artery with red, and the segmental artery with green. Here you can see the different internal circumferences of these arteries. And you can see that the internal circumferences get smaller as we move distally. And to talk about the diameters of these arteries, the renal artery's diameter was about 700 micrometers. The diameter of the branch of the renal artery was about 200 and 250 micrometers, and the segmental artery's diameter was about 100 micrometers. We have started with hypotarsum contractions to see the maximal and receptor independent contractibilities of these arteries. On the left-hand side, you can see the traces of these arteries, example traces. And on the right-hand side, you can see the bar graph for the hypotarsum contractions. And the hypotarsum contractions were lower, significantly lower in the segmental artery, but there was no significant difference between the renal and the branch of the renal artery. And then we have continued with our first vasoconstrictor agent, phenylephrine. and we have seen that phenylephrine contractions were significantly higher in segmental artery, but there was no significant difference between the renal artery and its branch. On the right-hand side, again, you can see the PD2 and Emax values, and you can see that the Emax value of the segmental artery was significantly higher than the other two. After the pre-contraction with phenylephrine, we have used acetylcholine to get relaxation responses, and here is an example trace for the acetylcholine relaxations, and on the middle you can see the curves, concentration response curves for the acetylcholine relaxations. And what we can say here is that acetylcholine relaxations significantly decrease when moved distally. And again, there was significant difference between the Emax values of them, but there was no significant difference between the PD2 values, so there was no significant difference in potencies. Our second vasoconstrictor agent was angiotensin II, and the angiotensin II contractions were significantly higher in the renal artery, but there was no significant difference between the branch of the renal artery and the segmental artery. And the Emax value of the segmental artery was significantly lower than the renal artery. And last but not least, we have evaluated the sodium nitroprusside relaxations, and the sodium SMP relaxations were significantly lower in the branch of the renal artery, but again, there was no significant difference between the other two. Also, here, there was no difference in the PD2 and Emax values. So, to conclude, in this study, what we have shown is that different arterial segments of the renal arterial bed shows different responses to different vasoconstrictor and vasodilator agents. So these differences might be important in certain diseases, as these arteries can be targetable differentially. The renal arterial segments were evaluated in the literature before us in rodents, and the differences to some vasoconstrictor and vasodilator agents were also evaluated in other animals, but to the best of our knowledge, this is the first time that these arteries were compared with each other in rats in response to different vasoconstrictor and vasodilator agents. So we might suggest that different receptor expressions between these arteries and differences in post-receptor mechanisms may be responsible for this differential responses. So further research might be needed to uncover those mechanisms. So I'm an MD PhD program student in Hacettepe University, and I want to especially thank to Güray Soydan, my PhD supervisor, for his supports, and Sinan Alperenkaya and Dr. Can for their works. And of course, to you for your attention and listening.
Thanks very much for Saltuk. Very interesting talk, very nice present. And a question for Saltuk. Any questions for Saltuk? So, okay, I had a question.
Yep.
You mentioned the LNAM be able to reverse the acetylcholine's relaxation functions on renal artery, right?
Yep, I actually forgot to mention that. In the presence of L-NAM and indomethacin, the relaxation responses were totally abolished, and in the presence of alpha-1 blocker, alpha-1 receptor antagonist, the contraction responses to phenylephrine was totally abolished.
Yeah, if acetylcholine's effect on different segment of renal artery is differentiate, so I imagine ENAM's abolish effect also affect at differentiate style. My understanding right?
Yep. There might be different enos expressions between those different segments of arteries, starting with the renal artery and going through the branch and the segmental artery. And that might be the reason for the difference between them.
And also, you think apart from renal artery, another part of our artery, for example, lung, they have a different branch out. Do you think the vessel in lung, in response to phenylephrine or acetylcholine, could behave similar as renal artery?
Yep, that is a certain topic of research, and we have also done research in the mesenteric arteries, different branches of the mesenteric arterial bed, but the pulmonary vasculature is definitely one thing I will check out for.
Yeah, all right, good. So, any question? Oh, number, is that right? Number 2, yeah, question for Saltuk.
Okay, thank you for your presentation. I would like to, your lowest effect was seen with acetylcholine relaxation was seen in the segmental arteries, so the distal one, and this one are probably the most difficult to set up in the myograph, I imagine. So do you have any histological confirmation of the endothelial layer in these vessels? And finally.
Actually, we don't have any histological proof for that endothelial function, but as I have said, we have also isolated the more distal branches, so we are more confident in segmental artery in terms of the endothelial functions.
Because when you insert the net inside the...
Yeah, there are wires in...
The little segmental arteries, you probably you are rubbing some endothelial cells.
Yeah.
Could explain the lower acetylcholine relaxation, for example.
Before these experiments, we have evaluated the endothelial functions, and with other experiments, and then we have started, but they were also functional studies. They were not histopathological studies.
Okay. Thank you.
Thank you.
All right, thanks very much. So I thanks our speaker and Rayomand, Danila, and Saltuk for your wonderful talk and also very active discussion with our audience. Our section successfully, complete. And I'm Xinjoy Wang, Professor of Molecular Cardiology and Pharmacology at the University of Manchester. I'm also Senior Editor of British Journal Pharmacology. So I wish everyone have a lovely stay in Glasgow and continuing enjoying the rest of our conference. And I would say summer is the best time in Scotland, enjoying your stay. Thanks very much. Okay, bye-bye.